Okay, there's just a couple entering the room, perhaps. Okay, good morning and welcome to today's academic meeting hosted by Division of Endocrinology. So we got Dr. Constance Adams, a fellow in our department, who's going to be an official consultant. So I'd like to congratulate her, one, for passing her endocrine certificate exam. And the second is that she was awarded the best poster presentation yesterday at the WITS Research Day. So well done to you, Constance. So we're going to be, well, Constance will be talking about a very important topic. It's hyperglycemia in a non-critically ill hospitalized patient. And I think the reason and the importance of this is that we have about 25 to 30% of patients that are hospitalized with diabetes, and another about 25% or 12 to 25% with in-hospital hyperglycemia, and they may not necessarily be diabetic. The big thing, and I think the challenge that we have at this hospital and also other state hospitals is that, and we're all guilty of it, we sometimes have these sliding scale charts. Nurses are doing their job. They're pricking patients 8 to 10 times a day, which is very painful. But we don't always check those glucose levels, or we may check it and not do anything about it. So we don't have that very proactive response. And we still have this very old-fashioned reactive response with a sliding scale, and essentially that's using insulin after the hyperglycemia. So I'm hoping Constance can unpack some of that today, and especially for the juniors and the interns who then move on to the next blocks, giving us consults for adapting and titrating insulin. Hopefully this talk will help them improve that. Constance?
If the guys online are getting this one is anyone good at this thing?
Probably have to just restart it. What about the tab up top display setting?
Yeah,
We have not presented.
yeah, I'm trying to get to this one.
That's, yeah.
There we go. So wait, make sure we're sharing the right one.
Yeah.
Right.
Yeah.
Okay. So, oh, sorry about that.
Hey, good morning, everyone. This is an outline of my talk. So, inpatient hyperglycemia has a 32% prevalence in patients who are admitted to hospital, both in ICU and non-ICU patients. It's associated with the high morbidity and mortality, as well as healthcare costs. So, with regard to treating it, hypoglycemia is the barrier to treatment intensification, and both hyper and hypoglycemia have adverse outcomes on patients. Some patients with inpatient hyperglycemia don't have a pre-existing diagnosis of diabetes, and this we label as stress hyperglycemia. So this is a large trial that looked over 6,000 patients, the prevalence and clinical outcome of hyperglycemia in the perioperative period in patients admitted for various surgeries. This was all patients admitted to the hospital, followed up over a 6-month period, who came in for most surgeries. They only excluded laparoscopic surgeries and surgeries that required less than 24 hours of admission. As you can see, that patients who had hyperglycemia had an increased mortality rate and higher rate of complications, including pneumonia, wound infection, sepsis and bacteremia, as well as urinary tract infections, a higher rate of acute myocardial infarction, as well as acute renal failure. So in the patients who didn't survive the admission, they had a higher glucose level before the surgery, on the day of surgery, as well as after surgery. And you can see from here that they also had a higher mortality rate with all those complications that I've just mentioned, as well as an increased length of hospital stay, as well as an ICU stay. So this graph is interesting. The top graph shows the mean blood glucose level in patients before surgery, and the odds ratio of a 30-day mortality rate was significantly elevated, more so in patients without a pre-existing diagnosis of diabetes than patients who were known with diabetes. As you can see, that the higher the glucose level, the higher the odds ratio for mortality, and there was no threshold. The higher the glucose, the increased rate of mortality. The inflection point for this started at about the blood glucose of about 7.8, which correlates to 150 milligrams per deciliter. The mean blood glucose after surgery as well was higher in patients who didn't have a pre-existing diagnosis of diabetes compared to the ones who did have. So this apparent paradox, where patients with stress hyperglycemia have a higher, worse outcomes and a higher mortality rate compared to patients with pre-existing diabetes at the same blood glucose level. There's a few theories to explain this. Possibly in patients that don't have a pre-existing diagnosis of diabetes, we don't start insulin timelessly. So we underuse insulin in patients we think don't have diabetes, despite them having inpatient hyperglycemia. Maybe because they haven't been exposed to insulin before, they've got a poor response. Possibly patients with known diabetes and chronic hyperglycemia already have had chronic adaptation to the stress of hyperglycemia in hospital. And acute hyperglycemia has been associated with higher levels of endothelial dysfunction and oxidative stress. Another theory is that possibly stress hyperglycemia in the acutely ill patient is not the cause of their mortality, but rather another marker of their illness. So it's a marker of the severity of their illness and not really the reason why they have adverse outcomes. So what are the mechanisms and consequences of hyperglycemia in hospital? Patients who are admitted might be on intravenous dextrose infusions. They might be receiving glucocorticoids. They've got a catecholamine surge as a response to the surgical stress of illness and anesthesia. They've got inflammatory cytokines. They might be getting high GI, parenteral, and enteral nutrition. This all results in hyperglycemia. So when patients are admitted to hospital, because of the catecholamine surge, they will have increased lipolysis with free fatty acid generation. They will have muscle breakdown with increased amino acids. They will have increased hepatic glucose output as well as gluconeogenesis. Because of the catecholamine and the glucocorticoids that might be given, they'll also have reduced peripheral glucose utilization, which will result in peripheral insulin resistance, resulting again in hyperglycemia. The hyperglycemia will also cause an osmotic diuresis with volume depletion and hypoperfusion, as well as electrolyte losses and acid-base disturbances, which leads to sepsis, multiple organ failure, and death. At a tissue level, hyperglycemia is known to reduce nitric oxide, so impaired vasodilation to critical organs, reactive oxygen species generation, endothelial dysfunction, which leads to vasoconstriction and thrombi with occlusion and ischemia, platelet activation, immune dysregulation with impairment of neutrophil function, as well as mitochondrial injury, which all result then in sepsis, multiple organ failure, and death. There's also a higher rate in infection rates, as well as poor wound healing in patients with hyperglycemia. So in a nutshell, inpatient hyperglycemia is harmful and should be treated, especially during the perioperative period in surgical patients. Most patients that have hyperglycemia aren't actually admitted for their glucose control. They're admitted for another comorbidity, as is evidenced by less than 10% of hospital discharges in the US list diabetes as the final cause or the reason for the patient being admitted. So it is often overlooked. So another reason, as I said, we delay treatment because we perceive hyperglycemia as a normal stress response, and we're still stuck with using sliding scale insulin, and we also fear hypoglycemia. So hypoglycemia is especially bad in the ill patient because they're unable to sense or respond to early warning signs. They're quite vulnerable when they're admitted. And we know that the blood glucose level of less than 3.9 can induce arrhythmias and cardiac events. This is either through the catecholamine surge and arrhythmias, but hypoglycemia is also known to directly impair cardiac function by prolonging the QT. When the blood glucose level gets to less than 3, this can be associated with severe neuroglycopenic brain injury, which can result in falls, aspiration, and seizures. It has been shown that the inpatient mortality for patients is higher when they had a blood glucose level of 2.8 at any time in their admission. So insulin is still the cornerstone of therapy for patients with inpatient hyperglycemia. It's easily titratable and rapidly adjusts control compared to oral agents. However, sliding scale insulin is still condemned by every endocrine society in the world. So this trial is the first randomized controlled trial that looked at sliding scale insulin and basal bolus regimen. As you can see, sliding scale insulin on the top didn't achieve a glycemic efficacy compared to basal bolus regimen. And here, patients initially put on sliding scale insulin, despite high levels of insulin, worsening hyperglycemia. As soon as they were changed to basal bolus regimen, they had improvement and normalization of their glucose control. So again, sliding scale insulin is not the therapy to be used for patients with inpatient hyperglycemia. Like we said before, it's a reactive approach. You're allowing the hyperglycemic event to happen and you're correcting it after the fact. It will result in oscillations of high blood glucose and possibly low blood glucose because of stacking of the different doses of insulin, and the hazards of its use exceed the advantages of its convenience. So now that we know basal bolus regimen is the ideal regimen for admitted patients, is there any difference between the different insulins? This trial looked at an analog detamir and aspart versus protopane and regular insulin. There was no difference in glycemic efficacy between the two. Again, looking at glargine and glutathione, which we have, opticillin and apidra compared to protopane and actrapid, also no difference in glycemic control between the two analogs. So what about premixed insulin? Most of our patients come with premixed insulin from home. As you can see from the top graph, patients who are on the first column is basal bolus insulin compared to premixed insulin. Also no difference in glycemic control between patients taking basal bolus and premixed insulin. And at the bottom, they're comparing the glycemic excursions before meals with 2 hours after meals. Also very comparable results. There's no difference in the mean amplitude of glycemic excursions between the two groups. So it does seem like premixed insulin has equal glycemic efficacy to basal bolus. However, if you compare the rate of hypoglycemia in patients taking premixed insulin, on the top in the first red block, the overall rate of hypoglycemia in patients who are taking premixed insulin was over 60%. The number of events were higher, especially morning or pre-lunch, and especially at night. Between midnight and 6 a.m. in the morning, many patients had hypoglycemia who were taking premixed insulin. So this study was stopped early because many patients on the premixed insulin group developed hypoglycemic events. We know why. Premixed insulin has a fixed ratio of short-acting to long-acting. It's really required to be eating regular meals for you to be able to take premixed insulin. So patients in hospital who have scans booked and procedures booked and need to be no per os at high risk of getting hypoglycemia in the afternoon, and especially during the night if they're taking pre-mixed insulin. So what about the hypoglycemia risk between different analogs and human insulin? This trial looked at a pooled analysis of the prevalence of hypoglycemia in patients treated with human insulin and analogs. For mild hypoglycemia, there was no statistical significant difference between analogs and human insulin, as well as for severe hypoglycemia. So the only other insulin that has shown some benefit with regards to reducing hypoglycemic risk is glargine U300. Glargine U300 was compared to U100 in a non-ICU setting. And as you can see on the left side, similar glycemic efficacy between glargine U300 and glargine U100. It's the same insulin, but U300 is just more concentrated. So you generally deliver a smaller volume, and that usually results in better pharmacokinetics of the agent. On the right-hand side, at a blood glucose level of less than 70, so at about less than 3.9, there was similar hypoglycemic events, but as you can see at a lower blood glucose level of less than 3, there was no hypoglycemic events in patients taking glargine U300. This is just a reminder of the different insulin profiles, and of note, the longer acting insulins, glargine and detamere. The Gludex not on this picture, but it's got the flattest profile and lasts about 36 hours. But the long acting insulins, glargine and detamere, have a very small peak, but a generally flat profile, and they generally last up to 18 to 24 hours. So most of them can be dosed as once daily insulin. All the trials had them dosed as daily insulin. And then just to remind you again, with the insulin premix, they've got 2 peaks. So a very high risk of hypoglycemia if the patient doesn't eat a meal 8 hours after the dosage. So this is just an approach to managing a patient who's got inpatient hypoglycemia. The target glucose we recommend is generally between 5.6 and 10. Less than 5.6 has been associated with adverse outcomes because of the risk of hypoglycemia. The targets are slightly different depending on the population. For example, a fasting blood glucose level, you'd like it to be 5.6, but a pre-meal blood glucose level, you'd like it to be less than 7.8. A random blood glucose or postprandial blood glucose, you'd like to be less than 10. Needless to say, patients with type 1 diabetes should always be on insulin in hospital, even if they know per os, but are very high risk of going into DKA, especially if they're starving or fasted. So what you would do is generally reduce their total daily dose of insulin at home by 20%. This is because in hospital, patients probably won't be eating well. They have an acute illness. Or you could start them off with 0.3 units per kilogram per day and give half as basal and half as bolus insulin. And remember to withhold granule insulin if their oral intake is poor. So generally they should be at least on a basal insulin. So with type 2 diabetes, the management largely depends on what the admission blood glucose is. So patients you think have mild hyperglycemia, they possibly don't have a pre-existing diagnosis of diabetes. They're coming in with a blood glucose level that's less than 10. They're on less than 2 oral antidiabetics at home, and they're insulin naive. This is probably the only patient you could consider watching for 24 hours and give them a sliding scale. The aim should be to see how many high blood glucose levels they have. If they're having at least 2 blood glucose levels of above 11, you should consider adding some corrective insulin the next day. So we say correction doses of insulin with rapid-acting insulin, slightly different from a sliding scale. You'd ideally want to check a patient's blood glucose before a meal. If it's already elevated before a meal, it can only go higher with the meal. So you'll give some corrective doses of insulin preemptively before the meal. It's different from a sliding scale where you're giving fixed doses of insulin every 4 to 6 hours. Patients with moderate hyperglycemia, these are patients who've got a blood glucose level between 11 and 16. They're on a number of antidiabetic drugs, and they're probably taking insulin as well, but so-called low doses, less than 0.6 units per kilogram per day. Patients like this definitely need insulin, and you could start off with basal insulin with or without correction. So a starting dose could be 0.2 to 0.3 units per kilogram per day, and then correction doses of rapid-acting insulin with their meals. Patients coming in with severe hyperglycemia, generally a blood glucose level of more than 16, patients they will definitely be diabetic and have a history of having high doses of insulin. You could again start off by reducing their home insulin total daily dose by about 20%, or starting them at 0.3 units per kilogram per day, with half as basal and half as bolus. Critically ill patients or patients presenting with DKA or HHS generally need intravenous continuous insulin infusion. So the blood glucose threshold we use to diagnose someone with stress hyperglycemia or inpatient hyperglycemia is more than 7.8. The target blood glucose for most general medicine and surgical patients in hospital is 7.8 to 10. But obviously the targets will be lax depending on the patient's comorbidities. For example, in terminally ill patients, patients with severe comorbidities, or patients where frequent glucose monitoring or close nursing supervision is not feasible, would have a target of about less than 11. Remember, in the elderly and patients with renal impairment, you'd start with much lower doses of insulin, like 0.1 unit per kg per day. So the next question will be, do you discontinue oral antidiabetic medication? There are obviously some safety and efficacy concerns with taking oral antidiabetic medication. You can't predict how they're going to work, especially the oral ones, and their use are limited by the delayed and unpredictable onset of their action. So sulfonylureas aren't recommended for inpatient use. Remember, they can cause sustained hypoglycemia, especially if they're taken concurrently with insulin. And again, elderly patients and patients with renal impairment will be more susceptible to hypoglycemia. Metformin, most of our patients will be on metformin, but by virtue of its mechanism of action, metformin does cause lactic acidosis. In a healthy patient, you can usually clear that easily with no problems. But in a patient who's got renal failure, they can't clear metformin. They've got hepatic failure, they can't clear lactate. They've got anaerobic metabolism, either from hypoxia or hypotension. They tend to get higher lactate levels. Patients who have impaired renal function or undergoing iodine contrast imaging also aren't recommended to use metformin in hospital. This sounds like the bulk of our patients will have one or the other of these conditions. Remember to also dose adjust metformin to GFR, and definitely don't use it below a GFR of 30. So no to metformin as well. Sodium glucose transporters. We know that they're the drug of choice now for patients with diabetic kidney disease and heart failure, as well as diabetes or type 2 diabetes. But the concern with them is the risk of euglycemic DKA, especially patients who are being fasted and who aren't eating well. They also have a higher risk of getting mycotic genitourinary infections, and because of the osmotic diuresis, patients are at higher risk of volume depletion. So the current recommendation from the Endocrine Society and the ADA is not to use SGLT2 inhibitors in acutely ill hospitalized patients. What about DPP-4 inhibitors? This is the only oral antidiabetic drug that actually has had prospective randomized controlled trials for inpatient use with the aim of limiting hyperglycemia. And it has shown comparable efficacy alone or with basal insulin when compared to basal bolus regimen. However, it only really works in patients who have mild hyperglycemia. So it will be a patient who is at a target A1C of 7% before admission, for example, and has very mild hyperglycemia in hospital. So the drugs that have been trialed are sitagliptin, linagliptin, and saxagliptin. Linagliptin is good because it also doesn't have a GFR threshold, so it's a possible drug to continue using in a patient with inpatient hyperglycemia. This is a trial looking at sitagliptin, comparing it to basal bolus and sitagliptin plus glargine. So also comparable glycemic efficacy in patients taking a basal bolus regimen, sitagliptin alone, as well as sitagliptin plus basal insulin. But if you see here, if you were to group the patient into a blood glucose level of less than 10, it did equally well with the other agents. But once the patient's blood glucose level was more than 10, there was higher levels of hyperglycemia in the patients taking sitagliptin. This is just another example of the other trials done with the other DPP-4 inhibitors. So it is the only well-studied drug, oral drug. So what about GLP-1s? We know GLP-1s cause a lot of nausea. That's how they work. People eat less because of anorexia. So it might not be a good idea for a patient who's admitted to be on one of these. They also work by reducing postprandial hyperglycemia, and that might not be the problem in a patient who is low per os. They might have fasting hyperglycemia. So we're not sure about their efficacy in the inpatient setting. However, we do know that in general, giving a patient a GLP-1 does reduce their insulin requirements and might reduce their hypoglycemic risk if they're taking less insulin. However, it's not yet well studied in hospital. So there is a trial that's currently underway looking at using an SGLT2 inhibitor with acute heart failure, started in patients in hospital. So we might get some more answers about these agents. So there was a study done with perioperative GLP-1 receptor agonists. They looked at 278 cardiac surgery patients. Only 16% of these patients actually had a pre-existing diagnosis of diabetes. And they were given liraglutide 0.6 milligrams on the eve of surgery and 1.2 milligrams after induction of anesthesia, and they compared this to a placebo arm. The primary outcome was the difference in insulin needed to control the blood glucose during surgery to a level of below less than 8. And it showed that there was an 18% absolute reduction in patients who required insulin. The dose and number of insulin injections was lower in the liraglutide group, and there was no difference in hypoglycemia. So that's a nutshell, but there are some other specific populations of patients in hospital who might have different targets or slightly different management plans for their hyperglycemia. I won't be talking about critical care, but perhaps Prof. Mo will give us some comments at the end. Generally, patients that are critically ill, transplant patients, etc., or have hyperglycemic emergencies should be on continuous intravenous insulin infusion. We also have a bit liberal targets for them, about 7.8 to 10, because hypoglycemia is associated with worse outcomes. Patients undergoing cardiac surgery, they have been well studied. Hyperglycemia increases deep sternal wound infections. Generally, aggressive control reduces the short and the long-term mortality. And this is one of the groups of patients where we would want tighter glycemic control and aim for blood glucose of about 6.1 to 7.8. Patients with an acute stroke, we want to stringently avoid hypoglycemia, so also have a bit higher targets for them. And the American Heart and American College of Cardiologists also recommend rapid lowering of blood glucose for patients who've had an acute MI. So what about patients who are on total parenteral nutrition? They obviously need to be on long-acting insulin, so they need to be on basal insulin, and they could probably be given 4 to 6 hourly rapid-acting insulin. Sometimes what they do is once they've worked out the patient's total daily dose of insulin and they're euglycemic, they add that whole amount of insulin for the day into the TPN bag and run it as an infusion with the TPN feeds. Patients who are on enteral feeds also require basal insulin because they're having sustained caloric intake. You could also add 4 to 6 hourly of rapid acting insulin for them with a sliding scale. But the problem with this, remember, because you're giving them basal insulin, if you were to inadvertently stop the enteral feeds, you'd have to consider the risk of hypoglycemia and continue giving the patient 5% dextrose. So the perioperative patient and the patient on glucocorticoids deserve some special mention. Most of patients who are admitted for surgery in an ideal situation should be well controlled before the surgery. So at a target A1C of at least less than 8%. 1 to 4 hours before surgery, their blood glucose level should be normal. And they should obviously be the first on the list. Then you would try and reduce their fasting time. If they're already on insulin from home, the night before, you would reduce their basal insulin by about 20%. And the morning of the surgery, if they are taking basal insulin, you'd reduce it also to about 80 to 75% of the usual total daily dose of basal insulin. Definitely hold metformin and sulfonylureas on the day of surgery, and at least basal insulin. But if there are no PAOS, you could do basal plus approach, which is basal insulin plus the correction doses of insulin. As I said before, studies looking at short-acting GLP-1s on the eve of surgery and at induction have been done. It's an area that might need a bit more work. And with regards to SGLT2 inhibitors, FDA recommends stopping them at least 3 to 4 days before surgery because of the risk of volume depletion and euglycemic decay during their admission. So glucocorticoids cause marked hepatic glucose production. Evening and afternoon hyperglycemia is very common. So patients who are taking high-dose glucocorticoids as part of a chemo regimen have severe hyperglycemia and end up requiring very high doses of insulin, usually in the range of at least 1 to 1.2 units per kilogram per day. So the difference here is that you would try and give most of this insulin as prandial and only 25% as basal. Patients who are taking intermediate acting glucocorticoids like prednisone or solumedrol, because of the profile of glycemia, if you were to give a dose of protophane at the time of the dose of glucocorticoids, you might actually match the hyperglycemia well and result in better control. You normally start at protophane at about 0.1 to 0.3 units per kg given simultaneously with a dose of prednisone. During the COVID pandemic, many patients were on dexamethasone. Dexamethasone is a long-acting insulin, so you'll get hyperglycemia for most of the day. So a good strategy for this is giving an intermediate-acting insulin like protophane twice a day. So you'd give BD protophane 0.3 units per kilogram with 2/3 in the morning and 1/3 in the early evening as a starting point. These are some the recommended anti-diabetic management of patients with COVID-19. So because of COVID, real-time continuous glucose monitoring became prevalently used in the hospital setting. It obviously centered on the ability of avoiding bedside capillary testing. This reduced the healthcare providers' exposure to COVID. It reduced the burden of diabetes care for healthcare workers as well. So what would normally happen is a patient would have a sensor in measuring their blood glucose levels every 5 minutes. If it is attached to a monitor at the nurse's station with alarms for both high and low sugars, it might work better at alerting healthcare providers to dysglycemia, and they might then intervene appropriately. However, studies are still undergoing with this because we're not sure about what's the accuracy of CGM during acute physiological disturbances. And the current recommendation is that if someone is using CGM in hospital, they should confirm all hypoglycemic events with a point-of-care capillary glucometer. Also, CGM would need to be removed for certain procedures, for example, MRI. So the Freestyle Libre Pro Flash is an intermittently scanned CGM. It's not real-time continuous. So the patient actually has to scan the sensor in order to get a glucose reading. They compared it to point-of-care capillary glucose testing in hospitalized patients with diabetes. On the left-hand side, you can see patients who are using point-of-care versus those using CGM had similar glucose levels, so they were on appropriate insulin regimens. On the right-hand side, the rate of nocturnal hypoglycemia was unmasked with CGM. And this is just most likely because we probably check blood glucose levels much more in the day than at night. So CGM might have a role in patients who have a high risk of hypoglycemia to actually monitor their blood glucose levels at night. It was strange because with the point-of-care device, what they found was that people just weren't actually checking sugars at night, but the CGM device was picking them up. So this was a study done in COVID, the telemetry study, where they looked at trying to manage inpatient hyperglycemia using technology. So the patient's got an insulin pump, they've got a CGM healthcare provider is virtual or remote and is getting the readings back and making appropriate changes to the treatment regimen. So in an ideal setting, CGM can be used if it's linked to the patient's hospital record. The doctor has access to the readings as well as the nursing staff, and you're able to preemptively manage problems even when you're not on site. Like I said, the main reason for this would be at least the monitoring hypoglycemia. So patients who are on insulin pumps, they can be continued in hospital, but it must be a center that's got experience with using pumps. The patient must be experienced with using their pump. They must have an ability to self-manage their diabetes. They mustn't have an impaired level of consciousness. Everything, the setting must be right. So the recommendation is that if the setting is right, pumps can be continued in hospital, but never started if the patient was never on one before. And if there's any problems with any of this, it's better to use a basal bolus regimen with multiple daily insulin injections. So in observational studies, it's been shown that closed loop insulin pumps do increase the time in range. We know this, that's why closed loop pumps are the preferred management of type 1 diabetes at the moment. So closed loop pump will be, the pump is secreting a basal rate of insulin. It's got a real-time glucose sensor, and it's able to suspend insulin delivery at a certain glucose threshold. So it reduces the rate of hypoglycemia and also alerts the patient to abnormal values. Pumps might be useful for patients who are on continuous feeds. So the consensus at the moment is that additional research is needed on CGMs and automated insulin delivery systems in the hospital setting regarding device accuracy, practices for deployment, data management, and achievable outcomes. And every center will have to have their own protocol. So when transitioning the patient to discharge, remember, it's always an opportunity to intensify treatment. So you'll decide what treatment the patient goes home with, depending on what their admission A1C was. If they were well controlled before their admission and they had an A1C of less than 8%, technically should be 7. You just resume their previous treatment. But if they have an A1C level between 8 and 10, you have to intensify their treatment. So whatever they were taking before, you'll try and increase it to increase doses. And you must consider adding basal insulin. If the patient was on basal insulin during the admission, you'd at least continue 50% of their hospital dose. However, if the patient has an A1C of more than 10%, they definitely need insulin. So you could decide to continue their other drugs and continue the glargine they were taking in hospital at least 80% of their hospital dose. So generally, when a patient's going home, you do reduce their insulin requirement from what they were taking in hospital, because again, there's the scenario is changing when they go home. And you must consider then starting basal bolus if the A1C is more than 10. So I think this is probably the part that a lot of clinicians don't consider, especially if the patient was admitted with a non-diabetes diagnosis, that it's an opportunity to intensify treatment. So there are some studies looking at starting GLP-1s at discharge, and liraglutide has been shown to be compatible to glargine with A1C reduction for a long time after hospital discharge. So it is safe to start the patient on a GLP-1 after discharge. Obviously, take the patient's comorbidities into account. There aren't any studies using the longer-acting GLP-1s. And if you look on the right-hand side, the risk of hypoglycemia was significantly less in patients taking GLP-1 compared to glargine. So we know this. This is why we like GLP-1s, and we're hoping that they'll replace insulin in managing type 2 diabetic patients. So some things that we should consider is what's the role of SGLT2s in hospital in acute heart failure. I'm sure the cardiologists are keen to trial that. And eventually getting a complete artificial pancreas with artificial technology. An artificial pancreas will be an insulin pump that's got both insulin and glucagon. It's able to sense glucose in real time. It's able to treat low blood glucose with glucagon and treat higher blood glucose with higher levels of insulin. But more research is needed. Oh, that's my presentation.